So there's not a whole lot of slides associated with today's lecture. So I'm assuming that the goal here is to actually talk about MedMath and IV dosing and figuring out all those MedMath problems. And at this point in your career, you're all in the mode of having to get 100% scores on your medication calculation exams. Am I kind of correct here? Like for your clinicals as well as in this class? Sounds familiar?
Yes.
So actually, can I borrow, I didn't have that particular handout that you had. Can I borrow that back from you?
Yeah.
Because let's take a minute here to kind of go through any questions that you all have regarding, the dose calculation practice. Because it sounds like we have actually we had a little discussion before everybody arrived, and the general consensus is the first question is confusing. It's confusing to me as well as to you. Apparently, there's been some clarification from Professor Crane. If you talk to me and say, what's the concentration of something per dose, I'm going to be thinking in this case, units per ml. You have 50 mLs in the bag, and the problem states there's 6 divided doses. So first off, what does 6 divided doses mean?
Over 24 hours, 6 doses in 24 hours.
So what's a divided dose?
You
Take
take
the
their
dose and give it
concentration.
6 times throughout the
Yeah.
day.
Okay, so
Every 4 hours.
so how every 4 hours, Q 4 hours.
24 hours, yeah.
Okay. So if you start out with 24 million units, how many units are you going to get per dose?
4.
4 million. Right. There's also a little question here about the vial contains 20 million, which is going to make you a little bit, you're going to need more than one vial to actually reconstitute this. So I think there's some confusion just in the way the question is structured. So if you're going to give 4 million units and you draw 10 mLs out of that 50 ml bag, and you mix that with your 20 million, let's say it's 24 million, just to keep everything consistent here, and then put the whole 10 mLs back into the bag with that 24 million units in it. Which is not really what that says, but
Yeah.
because you're supposed to give 50 mLs every 4 hours. So we're really not gonna mix up the whole, this is definitely confusing. You should be in essence adding 4 million units every 4 hours in 50 mLs. So if you have 4 million units in 50 mLs, what's your concentration?
0.08. Yeah.
Sounds good. 0.08 million units, which is still a fairly large number because you're going to just move it a couple orders of magnitude. So it's like, it should be about,
Should be 0.08. That's how she did it.
0.08.
She did it, but she put 20 over 50, which is saying it's not per dose, the total concentration shouldn't be what it is.
yeah, see that's, I think where we've got people, everybody's tired and confused. So for me, in a single dose, a bag, which has 4 million units in it, if you divide that by 50, right. So that's how I would get the concentration per dose. And actually, that's going to be the concentration. So the next question here was, how much NS is your patient going to receive over that 24-hour period?
300 ml. 50 times 6.
Yeah. Does that make sense?
Yeah.
So, do you think, we don't know enough about Mr. Alvila, but if he were a CHF patient, and he's come in because he's got pneumonia and so he's got CHF exacerbation, do you think that 300 mLs might be significant for him?
Yeah.
Yep.
So we're not really talking medication now, we're just talking about nursing. I have a patient who probably needs, we need to be listening to his lungs and paying attention to his, fluid, so that he's not overloaded. Okay. So we agreed that the first answer is supposed to be in liters. So instead of telling me 300 mLs, what is that answer in liters? This is a conversion problem.
0.3.
0.3 liters. Which, now the next question is how many mLs is that?
300.
300, right? So it's just, we're moving decimal points around here. So what are you going to set that pump to for each of those doses? What's the delivery rate?
Oh, no, sorry.
Yeah, 100 because it's 50 mLs.
It's over 30 minutes.
Oh, it's over 30 minutes. Okay, well then you're going to say, yes, you're going to set it to 100 mLs per hour because you're going to give 50 mLs in 30 minutes. So if you set it to 50 mLs per hour, it would take an hour instead of half that time. And I think we've discovered or discussed multiple times how many units you're going to get per dose. Should be what? 4 million, right. So going down to question G, that infusion is finished at 8:30, started at 8. When's the next dose going to be administered or started? Yeah, right. You don't care about when it finishes, you only care about the start time. Well, you do care about it. But in terms of calculating when your doses are going to be administered, it's the order. Were there questions about question 2? Dobutamine?
This is the first question. It was a wording.
So the first question was confusing because the wording, I think, wasn't what was intended. Question 2 is straightforward. Anybody have questions about question 2? So how do you convert her 165 pounds into kilograms? What?
Divided by 2.2.
Divide by 2.2, right? So what did everybody or anybody come up with in terms of how many micrograms per minute is this patient actually receiving of dobutamine? Sorry?
900 per beat.
900? Okay, so that's going to be 165 divided by 2.2 times 12, right? Okay. I'll take your word for it. I don't want to do that math in my head. I'm feeling lazy. So she's what, 78 kilograms? 79? See, that's what I get for doing it in my head. Rough. How are you guys at, doing like a rough estimate of where you think it should be before you actually grab your calculator?
Pretty well.
Pretty good. I mean, how would you approach the problem of converting pounds to kilograms? What are things you can do to make it easier to at least get a ballpark figure?
Cut it in half.
Yeah, divide by 2. And then what's going to be left over? That other 0.2. So you can also, well, no, let's not go there. If that's working for you, let's not. We won't go for alternatives like, multiplying by 10 and dividing by 10 anyway. Okay. So going on to D here, how would you find the number of milligrams in an hour?
You just convert micrograms to milligrams and times by 60.
Yeah, Or you can times by 60 and then convert. So how is a microgram different from a milligram? What's the magic number here? 1,000. Yeah, you know, the metric stuff is always in orders of, 1,000. Your magnitudes, micro, milli, nano. They always step down in orders of, 10 to the third. So you just get to move the decimal point, 3 places. It makes it fairly easy. That's what's nice about, I have to admit, that's what, I like the metric system because I can do things, I can divide by 10 pretty well. 2.2 makes it hard. So what's our delivery rate for the D5W?
Are we on?
I'm looking on E,
E.
which is asking for a minute.
$25 per minute. Miles per minute.
Yeah.
It's a
Are
really
you
small
gonna,
amount.
you're gonna be delivering us with a gravity system? Do you think?
No idea.
No.
Do you think it would be hard to figure out how to adjust, just with a little, in theory, it's possible if you have a micro drip delivery system, but you don't want to do it. Yeah, you want to have a pump, because these are all, drugs that can have a profound impact on whether the patient even survives the drug administration, let alone their current situation. Okay, so most of these are, pretty straightforward in terms of like figuring out volumes, multiplying by 60 or by 1,000 or both, and dividing. Let's take a quick look at 3 here. Did anybody have any issues with figuring out answers for question 3, doing your insulin dosing and stuff?
This page was the easiest page, the last page.
That one was real straightforward. Okay,
Yeah.
I'll take your word for it. I don't want to put my glasses on. I'm being lazy and I don't have to read all of this. So if you are saying it was the easiest page and you actually got through it all, that works for me. So shall we take a quick look at what the slides have to say? Did you all do all your reading? She assigned several chapters.
There's a lot of review.
They were all reviewed. It was like how to calculate and conversion factors. How many mLs are in a cup of
240.
240? So that's actually, if you give a patient, they ask for, a glass of water or a cup of water in the hospital. You already know, so 4 glasses is going to be close to a liter, right? So if they're on, strict I's and O's, you pay attention to stuff like that. But that's, that's handy to remember those things, because then you don't even have to do a conversion. You just say, oh, that's 240 mLs. So, dimensional analysis. So I like that term. In other words, figuring out the dimensions of the problem. What are we doing? Are we figuring out milliliters, milligrams? We're going to get, I'll hold off on IV stuff for a moment here, because where people get crossed up on that is that what do pumps deliver? How are they always set up to deliver?
Miles per hour.
They do mLs per hour. How are your drugs ordered? Milligrams, micrograms, grams. They don't know about how many mLs are, because that's where the confusion comes in, because you actually have, typically they're going to be diluted to some factor, and then you have to figure out how many milligrams, micrograms, grams there are per ml. And then you can figure out your dose. Okay. So let's take a look at the steps here. Identify the desired units. Good thing. Figure out your conversion formula with the numerator and place the rest of the formula in the denominator. Does that make sense to you? Okay. I mean, you talk about word problems. I look at something like this, it's like, and what am I supposed to do here? So it's probably easier to do in practice than it is to read about it. What are we canceling out here? It says enter the factors to be converted and cancel the unwanted unit diagonally. What is that instruction telling you to do?
To make make sure that the top and the bottom actually line up with the, yeah, units that you need.
So if I have something that's in milligrams and something that's in milligrams per hour on opposite sides of the equation, what drops out? Milligrams. And what, then my answer is going to be in hours. Okay. So those are, that's all that's saying. I like this part, estimate. To me, it's really important that you have an idea of what, in general, the right answer should be, or at least, what's the order of magnitude. Whether it's in milligrams or micrograms. If you're working with a calculator, what's the risk?
Put it in wrong and put it incorrectly into the calculator.
And so what would be probably the most likely kinds of errors when you're working with a calculator?
Missing a 0 or a decimal point.
Yeah, so you're off by 10 or 100 either way. You're either giving a tenth of the dose or 10 times the dose. So that's why it's important. For me, that's why it's important that you look at it and say, oh well, it's going to be about this much, and you get an answer back, and your calculator says it's 1/10 of that, or 10 times that, or a half of that. Maybe it's time to stop and rethink, review the situation. Okay, that's just being prudent, especially when you start working in. Not that it's not important on the floor. But when you start working in particular in the critical care units, you're dealing with medications that are, potentially very dangerous. And so, being off by a factor of 10 with, epinephrine or whatever is not going to be a good day for your patient. Either it's going to not be effective or you're going to have stuff to deal with. No. So, we have, let's see, dimensional. Okay. This is a tough problem. I don't know if I can figure this out. I don't know about you. So I have always struggled with teaching med math because I look at these problems, I do them in my head. I don't actually follow the formal rules. They just work for me. So sometimes when people ask me to explain how I got that answer, I'm baffled. It's like, well, I just know what's right. So. And usually I am right, and there's been times I've been wrong. Conversion factors, aren't these exciting?
Yeah.
Yeah, okay, good. Actually, I have a question. Actually, I put together a question for my juniors in Moodle that dealt with teaspoons and milligrams and dosing and mLs. They still hate me. In fact, I hated myself because I even got confused trying to figure out how to explain how to get the right answer. I got the right answer, but then I couldn't explain how to get there. Such is life. Boy, this is a tough problem. Okay, let's move on. So let's talk about safe dosing. Do most of you, hopefully, actually have an idea when you're giving medication of what is the dose per day for that patient? Does that make sense? So almost all of you are probably dealing with electronic records at this point, and everything's ordered in the pharmacy by electronically. And in theory, the pharmacist has looked at it. Do you think there's a risk that we can get a little complacent and look at it and say it must be right? Computer figured it out?
Yeah.
Yeah. So it never hurts. One of the things that went away when they went from the old system, where the doctor would handwrite the order in the chart, and then 4 of us would get together and say, what do you think that says? I mean, most of it was illegible. And then we'd come to a consensus, and then either fax or whatever, call the pharmacy and say, I need this, and then the pharmacy would put it together. In that process, there were a number of sets of eyes that looked at the order, and there were a number of opportunities to look at that and say, does that make sense? Does that really make sense? So with the electronic ordering, that has sort of been short-circuited a little bit. Doctor orders it, goes straight to the pharmacist. It doesn't go through you to the pharmacy, it goes to the pharmacy and comes back to you. So, since you're administering that medication, you really probably want to make sure you know what that drug is, how it works, what the maximum dosing and what the safe dosing is. I told the story last week, I think, about the Vecuronium patient that was bucking the vent. Okay. Then I won't repeat that. It's boring to repeat things twice. So if you saw an order that actually said in 3 to 4 divided doses, what would you think about that order? Is that a legal order?
No, it has to be one or the other, right?
Yeah, they have to be specific. It can't. In fact, they can't even order ranges. So, like your medication for pain, it has to be, instead of saying 10 to 20 milligrams of morphine for pain, it now has to say for a pain level less than 4, they get Tylenol. For pain scale between 4 and 6, we start moving into opiates and they get 5 milligrams of morphine. And for 6 to 8, so the orders have to be explicit and specific. They can't be ranges. It can't be left open to interpretation, because technically that means that you are making medical decisions about the patient, and that's outside your scope of practice, which is fine. So I see we decided it's going to be 4 doses here on the second line there. Okay. This is classic. Anybody have problems doing it this way? Or one of these ways? I need. Okay. Well, it wasn't that exciting. Any questions about how to do those simple dose calculations? I mean, they're pretty straightforward, right? Okay. When does this class end? We've got a half hour to go yet. Okay. Let's have some fun here.
I have more dashing target.
So first off, we're talking about solutions. Solutions are different than, they are technically a medication, but we're talking about, generally we're talking about volume delivery, we're talking about fluid replacement, balancing of fluids in and out. So what do you need to know before, if you're going to be trying to balance their eyes and nose? Yeah. Yeah.
Making sure it matches.
Yeah, so, if they're getting 2 liters a day of fluid and their output's only a half a liter,
That's a problem.
they might be having problems. Have any of you taken care of a sepsis patient that, is on the sepsis protocol? They just came in from the ED? Do you know what the sepsis protocol is? That's only relevant because we're looking at fluids. So sepsis is treated, the protocols are based on, we don't really know what sepsis is. Somebody that's in the underlying inflammatory processes are not well understood. But generally when somebody is profoundly septic, they have a tendency to go into, vascular collapse, and So when the heart is beating, where is the blood going?
Could be backing up into the lungs.
Hmm?
Getting pulmonary edema.
Well, yeah, in this case, usually what's happening is it's going from the heart to the lungs to the heart to the lungs, and it's not going to the extremities. And of course, one of the hallmarks of sepsis is increasing lactic acid. That's often considered a diagnostic. So where does the lactic acid come from? Okay, so with a patient who's septic, what do you think is going on?
Yeah.
I hear, yeah, what was the answer?
Their body shutting down.
Okay, so what's happening in those extremities that's making lactic acid?
It's anaerobic respiration.
Right, so basically they're not being certain that, that, again, we've had this vasal collapse. Fluid is basically just running in this circle as far as the body is concerned. And it's not going to the extremities, so they're starved for oxygen, they're anaerobic, they're putting a lot of lactic acid into the system. And when you look at what pH does to oxygen transfer and the ability for red blood cells to hold on to oxygen, which if I remember correctly, as the pH drops, the shift is that the red cells hold on to the oxygen, makes it even worse. So the empirical solution that they have right now for sepsis, aside from within 90 minutes you start them on antibiotics, is massive fluids. They're getting, I have seen patients over 24 hours gain 10 kilos. So 10 liters. And the goal there is just to flood the system with so much fluid that you're moving everything around. Of course, that has, other issues with it. Eventually, you're gonna have to get rid of that, but these people, they kind of swell up. Anyway. So let's talk about isotonic, hypotonic, and hypertonic. What happens when you are administering a hypertonic solution? What's gonna happen in the bloodstream and between the bloodstream and your tissue?
It's gonna be dry.
It's going to pull water out of the tissue, right? You guys haven't really had much opportunity in the ICU yet. That's up and coming, okay? So you probably haven't heard this, but maybe, has anybody heard a nurse talk about a patient being vascularly dry?
Yeah.
Yes, right. Who said that? So what was the situation?
I don't know, I just heard them say it about their patient when they were giving report. I had no idea what it meant.
Okay, so what do you think that might mean?
There's no water in the vasculature.
Yeah, they're dehydrated as far as the circulatory system is concerned. Do you think that patient could be a dentist? Easily. So what situation might lead to them having difficulty holding on to fluid in their vasculature? Okay, and what protein do we talk about most often? Yeah. So if somebody who's malnourished or they've got liver failure, their albumin is down to like 2.2, they can't hold on to fluid. So even though they are swelling and maybe they're experiencing, I think I mentioned anasarca last week, they're so edematous that they're actually forming blisters, that, the fluid is leaking out through their skin. They can still be dehydrated as far as the circulatory system is concerned. So they might get a hypertonic solution to help try and pull, fluid back. What drug might they even get? Do you think, aside from just a hypertonic solution of, like
When
some?
they give them albumin, when they hang a bag of
They will often hang a bottle of albumin. They don't do that actually very often. And I think there's two reasons for that. One, I think albumin is not cheap. And two, it's actually not very effective when you give IV albumin. It's kind of a last-ditch attempt. It's hopeful that you can sort of stabilize it. So we know what hypertonic is. If you're giving a hypertonic solution, you're going to be pulling fluid out of the tissues. And what happens with that fluid in general, assuming your kidneys are working well?
It's extreme.
Yeah, you pee, or they pee. But, yeah, they're getting the fluid, not you. Okay. And hypotonic, let's reverse the situation. What's happening now that when you're giving them, say, half NS, where is the water going to go? It's going to go into the tissue. Right. Okay. And with NS, which way does the water go? Assuming everything else is normal.
It's equal.
It's equivalent. Yeah, it doesn't particularly go anywhere. So, how do you figure out the rate that you're going to administer your IV solution? So yeah, you just take the however many liters over how many hours and divide that, and that tells you how many liters per hour, and your pumps deliver in liters per hour. If you have any of you had an experience in the emergency department where they're just hanging bags and no pumps, so how do they know how much they're giving and how fast? So let's talk about drip rate for a second. Is that probably in my next slide? Yeah, good. Let's talk about that. So, so what is this tubing drop factor thing?
Drop per minute, right? Drop factor.
No, the tubing factor tells you how many drops it takes to make 1 ml.
Oh.
So, in this case, we have a tube factor of 10. So that says every 10 drops is 1 ml. So if you want to give 100 mLs per hour, how many drops per minute is that with this setup? I want to give 100 an hour. And I've got this gravity set up, and it's 10 drops per ml. So I'm going to count the drops per minute in that. You've got to make sure that your drip chamber is open. If you fill the whole thing up, you don't know what you're running at. So you want to have your drip chamber so you can actually count the drops. So how many drops per minute is it going to take to yield 100 mLs per hour?
16.6666.
Sounds about right. So how did you get there?
So I did what I'm looking for, drops per minute, and then what I'm given is 10 drops per ml, and I set it up so that I have the drops per ml times how many we're going to be giving in an hour, so 100 milliliters per hour times how many minutes would be in an hour, 60. So I
Is it
multiplied
times
out.
or divided by?
It's all multiplied out. It's an hour over 60 minutes.
Oh, okay, so you're dividing.
Yeah.
Okay.
And then I multiplied the top and the bottom, so 1,000 divided by 60, and then I divided that to get my drops.
Okay.
That one is a little bit different because she
Yeah,
automatically
this is a
takes out
somewhat different
zeros.
question, right?
She did the same, but she took out the zeros on the last one, which is why people might get confused.
Okay. So how are you going to count those drops?
Count
I
them.
will watch. Yeah.
Yeah, you need a watch with a second hand on it, or a clock like this, or something. It used to be that you couldn't show up in clinical without a sweep second hand on your watch. I don't know that I haven't seen that in the policies here. The other programs I've taught in, you were sent home if you didn't have a watch, that you could actually do this and watch. Because you cannot, our brains do not allow us really to say, oh, it's counting, I can see it blinking once per second, and I'm counting that, and I'm counting this. I can't count. I was a carpenter for 10 years. I could not hold two numbers in my head at once. I could measure something, and if I thought about some other number, by the time I got there, it was time to go back and measure it again. So, same thing happens. The joys of being a carpenter. Same thing here. So, you know, you need, if you're gonna actually do that kind of analog calculation, we don't have a pump and we're just hanging a bag and they wanna run it at 100 an hour, you have to know what your drip factor is. And then, where would you find the drip factor?
On the bag. It says on
Which bag?
Or on the 2-big bag.
Right, it's on the tube. I have seen drip factors anywhere from 20 to 7 drops per minute, depending, or per ml. So you can't just assume that it's always 20 or always 10. And then, have any of you ever heard about a micro drop setup? Have you ever seen one? So instead of the normal drip chamber, you'll see that it has an extremely fine little cannula in it. It's metal. And usually those are set up so that it takes like 100 drops to make an ml. And that was actually how, before the advent of pumps, they used to deliver some of these more challenging drugs like in the ICU that are vasoactive. And what are our rules on rounding? Hopefully I'm not going to lead you down some path that's not appropriate.
0.5 up.
0.5 and up goes up. When do you round when you're doing one of these calculations? Do you round every step?
No.
No, at the end.
Why? Why don't you round every step?
You can increase your overall number.
It can change your outcome or change your final value because you have now introduced a rounding error. So the last thing you do is round. Other than that, you carry out, keep all the decimal places or whatever. Okay. Okay, so this has a drip factor of 60. So this is more like a micro drip. So it takes 60 drops to make 1 ml. And we're going to give 50 mLs over an hour. That's right. So the answer's right here, right?
Yeah.
Okay.
Yeah, that's correct.
Well, now you know how to do that. Okay. Yeah, and you wouldn't be running a micro setup much faster than that because it's just. What do you think the fastest rate that you can count in a drip chamber is? Accurately.
Probably about that.
Hmm?
It's like it's almost a second when it's almost 50.
You could probably get to 100 drops per minute before you really start falling apart. But yeah, 60 is probably 1 per second is not too hard to count. When it gets to 1.5 or 2 per second, 120, it's like you start losing, it's like, 1, 2, 3, 4, 5, and suddenly, that's, counting that fast when you're doing CPR is fine. When you're trying to actually count drips or drops, nah, not the best choice. So this tubing has a drip factor of what?
15 drops
Okay, so,
per ml.
right. So this is the thing to remember, and we mentioned earlier is that, IV pumps are always in milliliters per hour. So you got to always, figure out and as we said about dosing, what are your doses always? Are doses typically on a pump, are they in milliliters? When you look at the order, what does it say?
Milligrams.
Grams, milligrams, micrograms. That antibiotic that comes up says 1 gram over 30 minutes. So how fast are you going to run it? Well, I didn't tell you how big the bag was,
No.
so you don't know. You can't figure it out. You have to know how much volume you're going to move in that time. So if it's, whether it's 50 or 100 or 10 mLs, that tells you what your rate is. Okay. We're on slides. So what questions do you have? Do you have questions Or is this all crystal clear now that we've
I feel
talked
these
this
are
through?
very straightforward.
Yeah, these are really.
These are as
Like-
easy as it gets.
Yeah.
Because it doesn't talk about Mr. Jones, who had an accident on the way into the hospital and, you know, had a glass of orange juice in the morning. The trick with these word problems is they almost always include distractors. Have you heard that term before?
Yeah.
Yeah, they give you a bunch of extraneous information and you gotta figure out how to, like, I don't need that, I don't care about that. What is the question asking me? Is it asking me how many drops per minute? Is it asking me how many mLs, well, that's the same thing, mLs per hour, or micrograms per minute per kilogram? That's what you need to focus on, and you need to kind of ignore that other stuff. And I think to a degree that will help you de-stress about these, you know, these med-math questions. Typically, they're really not that hard in terms of the mathematics. But I think, you know, we invest it with a lot of anxiety because it's like, oh my God, I've got to get it perfect. Yes. But they're all really, the only reason that those problems are simple is because they don't have all the garbage around them. They're just saying, here's the problem to solve. And your challenge is to look at that, you know, 5 sentences and make it into that question. What is the problem to solve?